I thank organizers for giving me the stage to present our work here. I have this conflict of interest, nothing much. Balance is a critical for normal function, we all know, and pelvis is a vertebra which broadly determines what this balance has to be. And when we talk about global balance, we need to understand that global balance is not an individual and isolated measurement. It's probably composite of regional as well as segmental distribution. And any effect on either of the segmental or a regional one has a lasting impact on global balance. When we encounter a malaligned spine, what are our goals of realignment? And we all know that ISSG group came up with a strict criteria that there has to be a spinopelvic harmony with PI minus LL should be less than 10 degree. Does it give proper results? And multiple, again, the experience grows. Two large group ESSG and ISSG came up that the more you try to achieve this strict stringent criteria of Schwab, you encounter more mechanical failures in some subset of patients. So the ISSG revised their criteria and they came with a concept of age appropriateness, wherein we try to have that strict criteria in younger population. At the same time, we get some leeway, some kind of acceptable parameters as we encounter the elderly population. And that concept was encountered, actually encomposed by Yilgor et al. And they came up with a gap score. They not only incorporated the age, but they incorporated the morphometry of the pelvis, Rosoli's classification. They also incorporated the lumbar distribution, the lordosis distribution. They took into account where the apex should be in lumbar lordosis, how the inflection point should affect your spine, and that is how you have to plan your surgery in adult deformity kind of a surgery. And finally, the LDI came into play, which is widely used this day, and it is said that 60% of your lordosis should be at the lower lumbar level, that is 4-5-5S1. At least 2/3 is important to achieve a proper goal. So alignment goals are not a static number, but they must evolve into a patient's age, PI and morphology. So you have to compositely plan how to achieve this deformity correction. Now with this background, where does the minimal invasive surgery fits in? The paradox is minimal invasive surgery was popular for its ability to reduce tissue trauma, reduce blood loss and faster recovery. However, generally it is believed that the key limitation of this MIS procedures are insufficient lordosis restoration. Well, what is the fact? We know that these all fusion techniques, this is probably one of the most abused image you can see in spine conferences. It starts from PLIF, goes to MIS-TLIF, then the XLIFs or DLIFs, OLIFs and ALIF. And now we have one more LIF, that is transcambin approach. We call it KLIF, EndoLIF, whatever way you term it, but it's a transcambin fusion technique. So all this technique yields some kind of lordosis and some limitation. What are those? So first of all, you need to decide when you want to use minimal invasive surgery while restoring a lordosis. And again, ISSG group came up with class of deformities. So first two class are minor kind of a sagittal malalignment, and as you go higher, grade 3, grade 4 class has much higher sagittal malalignments. More sagittal malalignment you need to restore, lesser the chance you would want to choose MIS surgeries. MIS surgeries are more amenable for class 1, class 2 and majority of class 3 kind of deformities. However, when you go to class 4 and some of the class 3 deformities, you still have to go on and open surgeries. So which technique should we use to appropriately restore lordosis? Because lordosis is the workhorse of MIS deformity corrections. In countries like India, where cost is a major concern, where technical is a challenge, implant availability is still a challenge, MIS-TLIF is the workforce or workhorse for our deformity correction. MIS-TLIF widely used, but recently MIS-TLIF has started getting bad name because of its inability to restore proper lordosis. Now when you encounter this kind of a patient with higher degree of sacral slope, significant lumbosacral kyphosis, can we actually restore lordosis in this patient? Let's look at some of the surgical things which we could keep in mind while choosing MIS-TLIF as well as restoring lordosis. So before choosing any technique, you should know that how much lordosis you want to restore. If it is beyond a particular technique, maybe you will have to opt for another technique wherein you can achieve a proper lordosis. Whether your segment is mobile or stiff, because mobile segments are much easier to restore lordosis than the stiff segments. Stiffness segments would require further releases to achieve a proper lordosis. If you can see this particular X-ray and MRI, there is any subtle mobility is there, but with more or less, this is a very stiff segment. And to achieve lordosis in this patient, you will have to do a good release of soft tissues unless you want to achieve a kyphotic spine postoperatively. You also need to keep in account the surgical challenges which you may encounter while doing these procedures. And first enemy is osteoporosis. Osteoporosis, position. Sometimes, patients are in such an awkward position, specifically in this kind of patient where there is high PI, high sacral slope, and you want to do an MIS. Believe me, you will be operating with a very tilted microscope and a very awkward position for hours together. So you need to adjust for your position. We routinely give this kind of a reverse Trendelenburg position to achieve better ergonomics while operating on this kind of a patient. Always tend to keep a hip into or locked into an extension so that your pelvis is pushed into lordosis position before even you start your release in your patient. Then comes certain tips in MIS-TLIF which can give you a much better lordosis than we would expect generally. So whether you want to do unilateral or a bilateral facetectomy to achieve good lordosis. If your segment is mobile, even after doing a single level facetectomy, sometimes the segment becomes very loose. Those particular cases would not need a bilateral facetectomy. And however, there are rigid segments, also the kyphotic segment as we just showed, where probably bilateral facetectomy would be required. Now this bilateral facetectomy, this kind of a patient where facets are almost fused, can be done from monoportal from the same side ipsilaterally, or you would want to dock a tube on the other side to do a facetectomy and do your release. Distraction compression, like any other technique, is the mainstay. You achieve proper height and you leave a space for posterior compression so that the compression gives further lordosis in your patient. Expandable cage, lordotic cage can also be used to achieve proper lordosis. Mainstay of this entire procedure is adequate release. You need to do bilateral facetectomy in a stiff segment and achieve bilateral annular release from MIS-TLIF to achieve a proper lordosis. This is just one of the image where just a good release would nicely give not only reduction of kyphotic angle but also a proper lordosis. And from ipsilateral side, you can even do a contralateral kind of facetectomy, harvest your bone graft, do achieve a better release. Even the opposite side annular release is possible from this kind of a unilateral approach. And you can see this MIS-TLIF well done can give almost a lordosis of 20 degree from a kyphotic angle. When it comes to multi-level, OLIF or introlateral or ATP approaches are more favorable in this kind of setup. Here also you need to be aware that what is your primary purpose of this procedure. If your primary purpose is to achieve only segmental lordosis, the cage position becomes most important. You need to put your cage slightly more anterior so that again you can achieve a compression at the backside and achieve a better lordosis. However, if you have a case where you need to have indirect decompression, slightly posterior placement of the cage would lead to a better decompression in your patient. Having said that, keep in mind that you are not going too posterior, otherwise eventually you will end up having a kyphotic segment or will leave very little room for posterior compression. So using this technique, you can achieve a fabulous lordosis even with an MIS technique. ALIF is probably the treatment of choice when we come to L5 S1 level. I think nothing beats ALIF, but ALIF has its own challenges, particularly in a setup like where we work, where we have less trained approach surgeons. Cost is a constraint. However, we can still do that procedure and achieve a much better lordosis. The greatest challenge about ALIF is you really need to do a position change, and single position lateral OLIF FIS1 is possible so that you can save on the time. Sometimes we do encounter this kind of class 3 deformities where there is a very rigid segment. As you can see this, the osteophytes would hardly allow this spine to get mobile, where you have to plan your hybrid procedure to achieve a good deformity correction. So first, in this patient we plan to do an interior release by using an anterolateral approaches. We did OLIF, and that was in single stage, same setting. We flipped the patient prone. We did a mini open bilateral Wils's approach, could do a good Ponti's osteotomy, realign spine, and can restore a better sagittal as well as coronal profile in this kind of a patient. So in a nutshell, when you compare all this technique, ALIF leads the pack with maximum amount of lordosis correction possible, followed by OLIF, MIS-TLIF slightly lags behind, but if you employ certain technique, you can get away with doing good MIS-TLIF and achieve a better lordosis. Now that is the new baby in the town, and we call it a full percutaneous transcambient oblique interbody fusion. Where does this technique stand as compared to lordosis? So concept is again like OLIF, it believes in indirect decompression, it's full percutaneous, fluoroscopic guided, it gives excellent coronal correction, minimal blood loss, comparable outcome with MIS-TLIF. It has limitation, it does not restore your lordosis too much. You need to have a proper lordotic segment to do this procedure. It has a steep learning curve, and contraindications are just like routine indirect decompression, osteoporosis, severe stenosis, and a rigid segment. It is most ideal for single or double level fusion surgeries with preserved segmental lordosis, ideal for Rizzoli type 1, type 2 pelvis, preferred for in isolated coronal plane corrections, and combined with OLIF, ALIF, and TLIFs. Specifically, my choice would be in a very high BMI patient like this. You can see that this patient has a good potential to restore a lordosis, and doing percutaneous lumbar interbody fusion, you can restore your lordosis from 7 degree to 24 degree, because this patient segment was quite mobile and pre-existing lordosis was present. Most ideal in this kind of setup is combination of technique. No one technique can give you the desired result when you want to employ MIS. You need to have combination of all of them. Just a case example, this was our operated case 10 years back. We did MIS-TLIF, came back after 10 years with multi-level adjacent segment disorders. Now the challenge was to connect this lower segment with upper segment to do an MIS fusion. We did 3-4-4-5, OLIF 4-5. We just fixed it with anterior 2 screws, and 2-3 was done a transcambient fusion posteriorly. And you can see that, you know, it restored the profile, coronal as well as sagittal quite nicely. Another patient which, you know, significant sagittal and coronal malalignment, we combined open as well as MIS technique to achieve a proper lordosis in this patient. 5S1 and S2 AI screws were put from the midline central incision, and rest of the procedures, the lateral one and above transcambient procedure was done from the minimal invasive approach. And you can see that HV was restored quite nicely in this patient. So when to choose which technique, you know, again ISSG group has a criteria, but broadly you have to believe that when you want to do a multi-level fusion, go for anterior or anterolateral. When decompression is required, single or double level surgery you want to do, MIS-TLIF can give you a equally better result. Alpha S1, there is no alternative about OLIF, ALIF, but in a setup like where you cannot do ALIF, you know, Alpha S1, if TLIF is, if it is modified in a proper way, you can achieve a better lordosis. Finally, surgeon's comfort, familiarity, and training decides which particular treatment you would want to choose. In summary, pelvis dictates the blueprint. Combining Schwab and LDI gives much better outcome. Planning about LDI and segmental lordosis distribution is a very critical aspect in restoring your lordosis. MIS achieves a much robust correction in appropriately selected patient with proper strategic planning. Each approach has its specific indications and applications. A failure of MIS primarily is the failure to plan. Thank you for your attention.
Thank you. Thank you very much.
Thank you very much.
We've joined